Our final speaker is Dr. Jeffrey Turnbull. He is the Chief for Clinical Quality at Health Quality Ontario, and in this role his job is to provide clinical leadership to support HQO's quality improvement efforts. In his spare time, he also happens to be Chief of Staff at the Ottawa Hospital. And in 2001, I think it's significant to today's discussion, certainly, he established the Ottawa Inner City Health Unit, which works to improve the health and access to health care for people who are chronically homeless. Jeff, thanks for joining us.
Thank you very, very much for allowing me to be here with you today. One, I'd like to really say thank you personally to the Toronto Central LHIN, not just for having me here today, but for all of the work that you've been doing as it relates to promoting health equity, and certainly a beacon for all of the rest of us to follow. So thank you very much. And certainly I look forward to the discussions coming out of today and all of the other discussions that will follow as we continue to promote health equity right throughout the whole province. So in the brief time that I have, I'm going to try and talk to you about go from 35,000 feet to 1,000 feet. But I'm going to begin at the 1,000 foot mark and talk about certain service delivery models as we try and address the challenge of health equity within our communities. But at the same time, then think about, the thought would be, we can't do that in isolation without some overarching provincial strategy, because all of these things are wonderful in isolation, but as we heard from Lori, very, very hard work. So somehow, provincially, we have to think of structures that promote and facilitate ongoing collaboration and making our jobs collectively that much easier. So let's begin. So the context, I think we all know as it relates to health and health care and equity. The challenge is that Health Quality Ontario reported that the average life expectancy in Ontario was 81.6, and that our healthcare system was generally improving with all of the enormous efforts to transform the way we provide care in Ontario. However, we all know that there are pockets around us in each one of our communities who have not benefited significantly from this improvement in health services delivery. And in fact, 81.5 years, if you look at some of our populations, we also reported in measuring up that if you go from the north, or the rural areas and to the urban areas, there's a 6-year drop in life expectancy as you go into our northern communities. That's a very significant amount. In my context, in those areas that are in the inner city population, the likelihood that you're going to get to the age of 75 is only 25%. If you go from the richest part of Hamilton to the poorest part of Hamilton, your life expectancy will drop 21 years in that 15-minute drive. So we lose the richness of the data and the importance of the true impact of health inequity by looking at average numbers. And I think that as I come back to this at the end of what I want to say, it'll be the importance of having meaningful data at a community level, right down even to an apartment level, that will allow us to design effective health services delivery models. So, some of you may have heard me talk about this. There are 3 levels in my mind about the challenge of equity and our relative success. The first of all will be equity and access. Can we provide all those in Ontario access to reasonable health services? And for me, if you were to look at my homeless population, Ottawa has relatively good health service delivery. So you'd say, well, they have access. Well, my homeless population do not have the same access to health services delivery. One of my homeless individuals will not get onto a wait list for a total knee joint replacement. It just will not happen. It's not as if they're going to wait longer. They're just not going to get onto a wait list. So they're not going to have access despite the fact that that service is available in our community. It may not be accessible to them. It may not be appropriate for them. And so the challenge is for this, as we think about access, is we have to think about the right care at the right place, at the right time, for the right individual. And not one size is not going to fit for everyone. And that is the challenge that we're going to have to face right across this province. Wouldn't it be wonderful if we had equity in outcomes? That meant that if somebody had a stroke in one of my shelters, that would be the same if somebody from the highest socioeconomic bracket had a stroke, and their outcome would be identical. That is just not happening now, and it's going to be a real challenge for us to tackle that one. But the holy grail would be, if you were born today, no matter who you were born by, where you were born, what socioeconomic bracket, what cultural, racial, or socioeconomic group you came from, you would have the same potential for health. Now, wouldn't that be wonderful? But we are so far from that. We've got a lot of work to do. So that's the challenge. The additional challenges that I've mentioned in the past, the socioeconomic challenges are growing for all of us. Social inequity is growing. Some say that in Canada it's growing faster than other areas in the developing world, and with that, health inequity is growing. So we have a major problem, and not only do we have a major problem to challenge and deal with, but that problem is getting bigger by the day. So as we think about different quality frameworks and we try and put equity within the context of quality frameworks, it's important to say that we started off in many of the quality perspectives and initiatives thinking about safety. We then moved to effectiveness and efficiency, timeliness, care. Patient-centeredness is now an important part of that. But we're just starting to get our heads around the concept that equity is probably as important, if not more important, than many of those others. I have a feeling that we're not going to be able to get the life expectancy in Ontario much greater than 81.5 years until we start to look at the lower end of the left-hand side of that curve. And that we stop investing more into health services for the wealthy populations who can actually access health services pretty well without us. And we start invest in health services for those people who are not capable or otherwise advantaged enough to access services without us. And so I think we're going to have to start to invest more in populations on the left-hand side of the Bell distribution of an age life expectancy curve. And the more we invest there, I think we're going to see a greater return on an investment in terms of some of the outcomes. Now let me just go from that higher level down to what I think would be the lessons that I've learned as it relates to delivering services for the homeless population. And like Lori, I have no idea what I'm doing, but I've learned many different things with many important scars. I thought I was going to just deliver 15, 20 years ago. I thought I would go down to the shelters and just deliver a few antibiotics, and that would be great. We'd treat some pneumonia. Then I recognized that I couldn't do that without having the full participation of the community around me. We had to define the nature of the community that I was serving. We had to consider some of the barriers that they were dealing with on a regular basis. We had to engage them, truly engage them and their communities in the care that they felt was appropriate. Not that I felt that it was appropriate, but they felt was appropriate. And then we had to start to think about what some of those social factors that were mitigating or preventing them from accessing care. And how do we actually try and deal with that as we try and provide care? And then define and measure successes on their terms. Those were some of the lessons that I learned. And so let me just say that we started off in the inner city with 30 beds. We're now over about 250 beds when I did rounds last week, and tomorrow I do rounds again. It'll be, we'll probably have a few more. We're growing by the day. We're about the size of a medium-sized hospital now. You can see where we have beds allocated. We have managed alcohol programs. I'm going to tell you very quickly about TED in a moment. We have step-up, step-down units from hospitals. We have a hospice for the dying homeless. We've now bought a third hotel in terms of supportive housing, so this would be our third supportive housing initiative. And we have a primary care clinic. We have a vet clinic. You name it, we have it. We have about 150 personal support workers roaming the city, finding people under bridges and fields. We have a dozen or so nurses, 3 nurse practitioners, a psychiatric outreach nurse, myself, and a psychiatrist who provides some consultation support for us. So, and we find ourselves in 7 different facilities with 9 programs. The principle is the right care at the right place at the right time on their terms. And that's why we started delivering services actually in the shelters. And we have wards there. I give oxygen, IV, I give all sorts of therapies in the actual shelters themselves. I do abdominal taps, minor procedures. I beg and borrow and I steal, and I get my consultant colleagues to come and join me on rounds so that they can start seeing what this is like. And now our surgeons have actually started a clinic in the shelters with us. So that's the nature of the program. Let me just tell you very briefly in the moments of one of our last programs. We heard from our paramedic colleagues, our emergency room colleagues, and our clients themselves that, this business of being found at the Rideau Mall intoxicated and then suddenly brought by ambulance, fire, 911, ambulance up to the emerge, detox for a little while, and then be released from the emergency department. Everybody found that this, and clients included, found that this was an enormous waste of time, money, and was not promoting their care in any way, shape, or form. So we said, all right, I understand that. What we'll do is we'll set up a small area in one of the shelters, and we'll have algorithms and protocols. So when police and the paramedics are called to an individual at the Rideau Mall, they'll bring them to us. They'll sober up, and then the next morning, we'll talk to them about getting into our treatment programs, whether that be a managed alcohol program, whether it be a detox program, or housing program, or social support program, and can we help you deal with the police, and all of those things that you have learned on a regular basis to deal with. So we were funded through our LIN for that for about 150 encounters. That first year we had 850 encounters. The next year we had 5,320 encounters. That was true diversions. Everybody started to bring people to us when they're intoxicated. This was not just the ambulance and the police, this was OC Transport, this is the Rideau Mall, this was their buddies. These were people who were looking after rooming houses. This was the place to be. The nurses love it. It's just like Mad Max and the Thunderdome. And so it's wild and crazy. But in the next morning, those people they sober up. We talk to them about better care. Some of them come into our programs immediately. Some of them say, no, I'm willing to continue to rage for a while, and they do, and then they come into our programs. But the net result is, for that number, there was true diversions, 3,400 true diversions that would have gone to the emergency department. That's $700,000, and our expenses are around $300,000 to run the program. So you can provide better care, patient-centered care, on their terms, get better outcomes, and save money. So I think the challenge is that we have to look at other circumstances, and that I think we have to think about ways that we can generalize these good ideas to other settings. So let me just take the last few minutes and talk about a higher level. How are we going to move to making this not just something that's happening in Toronto or something like good stuff happening in Hamilton or other places, how do we spread that? How do we actually make this a provincial-wide initiative? Health Quality Ontario is addressing this issue, and they have said that they think that equity is an important quality principle, and they're trying to develop a strategy right now over the course of this year to say, how can we be a constructive player in that role? And so we look forward to the outcomes of today, other settings where we'll have a chance to speak to almost all of you in terms of how can we be a group, an agency of good rather than evil. How can we support and promote things? So if you look at some of the things that Health Quality Ontario can do, setting a path for quality. So making equity an important priority at all levels of health services delivery. Monitoring and reporting. Well, could we be the people who could help provide you data on a regional basis about vulnerable populations or disadvantaged populations? Could we submit, for example, a report card annually based on populations and equity-sensitive indicators saying, this is how we're doing as a province on an equity report card? Could we think of some of the best practices about there based on evidence? Could we think about what we need to know and how can we spread that out to other communities? Could we embed quality improvement and equity strategies in all of our work, not just through important LHINs like Toronto Central, but right out throughout the whole province? Could we work with partners? We heard the importance of partnership, something that HQO, I think, has a significant track record in and can play that important role going ahead. And certainly, can we engage the public and the providers and patients effectively in what would be an equity strategy that would promote better health for all Ontarians? So I'll end at that point in time. I'm happy to answer any questions, but I think that we've all been engaged in fantastic initiatives at a local level to address the issue of equity. What we now have to do is up our game a little bit more. This has to be done at a provincial level. We have to allow those people who are working at a local level to succeed, and we have to facilitate all of the work that's going to take place from Thunder Bay all the way down to London, Ontario. And we have to support those communities who find themselves most disadvantaged around us. So I'll stop at that point in time, and I'd be happy to, if I'm allowed, questions at any time.
Absolutely. Thank you very much, Jeff. We are going to take 2 questions from the floor. I'm going to lead off with one quick question, however, and it's a question that Steny asked to the panel earlier, and it concerns accountability and how we can see that health leaders are accountable for ensuring good results when it comes to health equity. Any thoughts?
So first of all, we have to provide meaningful data on outcomes. You can't hold somebody accountable without providing them outcomes data and how well they did. I think there's many different ways that we can do that through Health Quality Ontario, through its annual reporting process. That's one way. We can do it through holding groups accountable, and I understand you discussed this through the quality improvement plans. Could they be widely spread, and could equity find itself within a quality improvement plan? We have health links. Those health links all around us, could we not hold them accountable for an equity platform? Could we start to provide important tools and give that to providers, such as poverty assessment tools or health equity assessment tools? Could we have those tools available and then hold people accountable to make sure that they use them and report to them? So you can't hold somebody accountable unless you actually give them the data, and then actually you can reward and recognize their behaviors as they meet those goals.
Excellent. Thank you. I have a question right here.
Hi, my name is Judy. I'm a frontline worker from Central Toronto Community Health Centers, and I'm asking this question and share with you some of our thoughts from my colleagues. So it's a joint effort. So before I ask this big, massive question we have is more of a reflection, I'm going to give some context. So our ED, Angela Robertson, sent us through email a newsletter from the Association of Canadian CHC recently. In there, it talks about the government is cutting funding to healthcare, and it's further eroding our universal healthcare system, pushing toward privatization of healthcare, and we have a government who refuses to recognize that that colonialism is a key to all the deaths and the missing Aboriginal women, and we as frontline workers, we continue to go to too many memorial services, all the folks that we work with on the streets. So I work in the homeless harm reduction team at Queen West Community Health Centers. So this morning we have speakers who talked about, is there enough money in the federal level to provide health care? And we're asking the question, should we also think about how we can restructure our economic system and the ideology behind our present economic system so that we have enough money for health care? And like what Angela was saying, to look beyond the cycle of election and party politics. So here is our big and massive question in the context of our federal election is coming on October 19th. So our big massive question is, we don't expect the answer, but this is our reflection, is how do we achieve health equity within our present neoliberal, capitalistic, evidence-based system, where our current economic paradigm roots us within an inequitable distribution of wealth, which is strictly in opposition of the key principles of health equity. So that's our big reflection.
More than a reflection, I think it might be at least a PhD dissertation, in fact. But an important point I'd like to note, we've done pretty well. It's 1:30. We hadn't mentioned the federal election yet. But Jeff, here you are in Ottawa, the nation's capital. Any thoughts on how politics might intersect with some of this?
So I'm always amazed at this discussion because we know that doing this is the right thing to do. We actually know that it saves money. It doesn't cost money. So if we're not doing it because it's the right thing to do, that's too bad. That's our fault. And we're doing it and it's costing us more money, that's really bad economic sense. So why is it that we continue to go in this direction? And I don't know the answer to that, but it's caused me a great deal of discomfort when I start to think about some of the explanations for why that might be. But maybe we've failed a little bit in that we have not framed the conversations enough in an economic argument for those people who are driven by economic solutions. Maybe we haven't done return on investments as clearly for early childhood education, for example, or housing strategies. But I can tell you, all of you can tell me, I look at my average cost of a homeless individual in visits, fire, 911 to the emergency department, hospital admissions. One of my guys was in hospital 191 times in the 6 months before coming into the program. $1 million, they can go through $1 million in a heartbeat. So a lot of costs. It's the way we frame the argument, and I think we have not galvanized partnerships well enough. We haven't joined with the community groups. We haven't joined as well with the religious affiliation groups. We haven't joined enough with service-oriented groups, and we're still speaking in silos.
Last question.
Hi, Jeff.
Hi.
Nosha Badigani from Health Quality Ontario. So it's not really putting Jeff on the spot, I promise. But in the conversations I've heard today, and I've been interested in health equity and worked in this area for a long time, but it struck me today that for the first time, I feel like health inequity is actually a chronic condition. And rather than talking about initiatives, I think we need to make a sustained commitment, the same way we would to primary care, that we can't have this as a short-term plan to get to equity and then say, okay, we've attained it, because it'll have to be sustained. So in putting together Health Quality Ontario's strategic plan, I'm wondering how are we going to see sustained commitment? When I listen to Lori talk about her program and that the money's going to have to be moved, it strikes me that they might sustain it for a while, but there's always the risk that it'll slip back without regular management.
Yeah, so I think that speaks to the need for us to make fundamental structural changes, not just same structure, doing things slightly different. I think we have to restructure the way we deliver services. Maybe we have to think about different ways of funding those services. And at the same time, I think ministries have to restructure because this isn't a housing issue, it's not a social services issue, it's not a treasury issue, nor is it a health issue. I think when we have meaningful structures that change, then we'll get greater sustainability, because I think, Nashiba, you're exactly right. As soon as we turn our attention on to something else, it'll move back.
Hear, hear. All right. Thank you very much, Jeff. Thanks for joining us this afternoon.